Good afternoon, everyone, and thank you for joining us for another one of our free MAG educational seminars. Today we have the lovely Dr. Divyanshu Dua, an oncologist, and the session today is about errors in cancer treatment. Dr. Dua is a consultant medical oncologist based in Victoria. He trained in internal medicine and medical oncology in Australia before completing a clinical fellowship in drug development, early phase trials, and thoracic malignancies at the Guy's Hospital in London, as well as the Sarah Cannon Research Institute. Thoracic malignancies, including lung cancer, mesothelioma, and thymic malignancies, continue to be of special clinical interest to Dr. Dua. He also has particular interest in the treatment of malignant melanoma, breast cancer, genitourinary cancer, sarcoma, and neuroendocrine cancer and tumors of the central nervous system. He has also been actively involved in teaching and research of cancers in older people. Just a little bit of housekeeping before we begin. If I could please ask that you all please remain on mute so that no noise from your home or workplace does not affect the quality of the recording. You'll be able to unmute and ask questions at the end of the presentation, or you can type your questions in the chat if you need to go or don't want to unmute yourself. The recording will be sent out to you within a day or so, along with the slides. It will also be available on our YouTube channel for viewing at your own convenience. Without further ado, I will now hand you over to the lovely Dr. Dua. Thank you so much for giving your time today to deliver this session to us. Now, over to you.
Thank you for the opportunity to have a presentation today. As Taylor said, I'm a medical oncologist, and I have been in the medical legal for the past 10 years or so. Today's topic is really to find out when things go wrong in the cancer treatment, whether it's the oral treatment, whether it's the IV treatment, and what are the clinical parameters, what is the medical legal in the oncology practice. So today's topic, we're going to try and cover what is the scope of medication errors in oncology. We're going to try and make some difference between the oral versus the IV chemotherapy errors. What are the patient factors? What are the nursing factors? What is the impact of harm, litigation, and system failures, evidence-based solution, medical legal implications, and how we can actually improve our practice. I think it's important. Cancer treatment in cancer journey itself is actually quite difficult. It comes with a lot of trauma for the patients. It's a life-changing event. And an error in cancer treatment obviously puts a new level of complexity onto it. So cancer treatment involves narrow therapeutic index because these drugs are highly toxic. So we really need to make sure that we're using the right drug at the right time at the right doses. Obviously, there is a complex workflows these days between the doctors, nurses, pharmacists, and there are multiple failure points. It's as an oncologist, you see the patient, you come out with a plan, you discuss a particular chemotherapy regimen, then you put an orders, which is checked by the pharmacy. Pharmacy has got a question, comes back to you. Then it actually goes from the pharmacist onto the nurses. Nurses make the final check, and then the patient gets actually the drug. So you could have multiple failures, as you can see, if obviously the processes within the oncologist and the training pharmacists and they're checking, nurses, final checks. Although these checkpoints are there, but obviously it creates obviously now there's a double or triple layer of humans, which involves and multiple levels of systems, which involves and that's where you can have the multiple failure points. Obviously, these errors are preventable, but obviously when these errors lead to preventable harm, cost, morbidity, litigations, and based on the literature, 2017, that patient-reported error rates are between 13 to 25%. So 1 in 4, there is a possibility of having an error within the oncology. Saying that one, the error, this obviously depends really on the location. This really depends on which center you're practicing, etc., and what other services you've got as well. So type of errors are really omission, which is basically failure to act. So obviously there is a situation where we see in oncology where obviously you find that the patient's cancer treatment has progressed, but you're not giving him any treatment, or you're actually taking a wrong action. Such an example are wrong dose, wrong frequency, incorrect infusion. You did not provide them with the supportive medications. You failed to identify the toxicities. One of the most common example that I've in the last 2 or 3 years been involved is there's been multiple occasions where women with breast cancer got a chemotherapy which affects nerve ending, and that's on led to the permanent nerve impairment and morbidity, which could have been easily stopped and prevented as well. You given them inappropriate oral therapy instructions. You did not provide them education. You did not tell them this needs to be taken twice a day. You didn't tell them whether it's before food, after food. You didn't understand what kind of a side effects, what kind of precautions patients and the family members needs to take, and exposing to the families and relatives. And also the other issues around the miscommunication during the handoffs, where basically you're handing over the patient from one doctor to the other, or you're actually handing over from one team to the other. Then there's always been a miscommunication. So those are the stuff that can actually happen. What is the scale of the problem? The studies have shown that there is a 1.7 medication error per patient within the 12 weeks of starting an oral anti-cancer therapy. There is a 5.2% of the chemotherapy prescription contain at least one error, and 327 errors in 201 patients receiving chemotherapy in Iran. But that's not a reflection of what we do, but these numbers are from the published data. Patient-reported harm. So 13% of the oncology patients perceived an error. One-third of these caused severe harm. Only 45% received an explanation, 35% an apology. Obviously, when there is an error, when you do not communicate to the patient, that actually increases your medical legal risk as the communication levels are poor. Nursing reported error. 67% of the oncology nurses witnessed an error in the past 6 months. 74% occurred during treatment. 23% were associated with chemotherapies. Causing was 55% nursing factors. It could be the rate. It could be pre-med. We omitted a pre-med, or we forgot to give them the discharge medications. Doctors' factors was basically right dosing. Chemotherapy drugs are based upon your height and weight. So there could be an issue where you not check the last weight. You're still giving them the doses based upon the weight when they started the treatment, and the weight has not been checked, weight has not been modified. Any doses, any any change in about 10% of the weight will cause a significant amount of chemotherapy dosing change, and that will also account for side effect. You also have to be account for the systemic factors, workload, documentations, etc. as well. When can the errors occur? The errors can occur across the cancer treatment. It can occur at a point of diagnosis. The biopsy needs to be, because we as an oncologist, we go and read the biopsies. If you're not sure, we go back to the pathologist. We go back to the MDD. We discuss it. We look at the slides. What we prescribing could be wrong. How we transcribed this diagnosis and treatment onto the letters, how we actually communicate to the other doctors, other surgeons could be an error, how the drug is dispensed could be an error. We could be saying, just example, chemotherapy drug A with another compound, or chemotherapy drug A with another compound. What we actually ordered might be totally different to what the patient might go, because the pharmacist may not make a difference between, such as cyclophosphamide, the chloride versus cyclophosphamide phosphate. It just means the drug concentration does actually change. So obviously, what's prescribed has to be dispensed, how they prepare the drug, because it is some drugs, all drugs needs to be manufactured. So those, in terms of how they prepare, how they did the calculation, etc., how the drug is administered, such as the pump rates can be done, and how we monitor, which comes back to the oncologist or the nursing staff, how we monitor for the side effect can have the error as well. Most errors in IV chemotherapy occurs in prescribing, which is different to oral chemotherapy, but the drug errors in the making the drug is actually low, is around 8%, and how we administration is about 1%. So you can actually see the difference between the IV and the oral chemotherapy. Examples of oral chemotherapy drugs are you've given them the wrong daily dose. You can just say taking once daily when it has to be double the dose. You're missing or doubling the doses. Taking on an empty stomach when contraindicated. You forgot to ask what over-the-counter herbal medication do they take because that makes a difference how much they actually absorb. You forgot to stop the over-the-counter medications. Obviously, the biggest key factors in any oral chemotherapy is patient education and documentation must be very sure what we're doing. IV chemotherapy error hotspots are really wrong dose due to calculation error, incorrect body surface area, which is a calculation between weight and height. And any 10% change in the weight will cause a material impact on the body surface area. The transcription mistake, what you plan to do versus what you actually write to do is actually different. Uh, Wrong infusion or volume is quite common. It's about 20% of the doses as well. So we get called by the oncology unit. This actually was supposed to be in a liter bag of saline, but it came only in the 250 mils, which increases the concentration. So we have to cancel the patient. We have to rebook the patient. So those things are not really uncommon. These things do happen. Catastrophic errors where a significant amount of drug has been given, which was not planned to, which obviously causes significant toxicities. The biggest example is obviously a four-fold increase in cyclophosphamide in a study published. Other drug is vincristine, which is extremely irritant to the veins. It is extremely irritant. You can actually see the nerve being hardened within a few hours of giving the drug through the vein. And just imagine that we pump this drug through actually the nervous system, which obviously caused a significant catastrophic event. These events, and we also have seen the effect on the nerve endings with breast cancer. We've actually seen the medication such as to strengthen the bones, which can actually cause the jaw necrosis. So there's lots and lots of factors or lots and lots of examples of the drug, if not given right, can actually cause trouble. Just that obviously these errors have got a significant medical legal significance because these effects define negligence and the breach in the duty of care. Case study published by Dixon in 2025, dexamethasone mismanagement. Multiple doctors prescribed dexamethasone without a coordinating taper. There was no structured handover between one doctor to the other. Documentation was inconsistent. Patient received continued steroid excessively, harm risk, and we know the long-term impact of steroid can cause diabetes, can cause cataract, can cause significant weight gain, etc., and also predisposes you to infections. Obviously, the transition of care from one doctor to the other are quite important. Systemic failures, the root causes across articles are repeated themes, miscommunication across discipline, the surgeon referring to the oncologist referring on to the palliative care referring back for radiotherapy, or we referring back to the radiotherapy. I think the communication has to be clear. Documentation of a plan from one to the other is important, but absence of structured handout. How do we hand over? Are we giving a verbal handover? Are we giving a written handover? Are we writing letters? That is quite important. When you do not have a pharmacist involved, whereas some of the centers currently that we work with, they do not have a on-site pharmacist. So that can sometimes lead that we obviously lacking the oral chemotherapy education. So there it comes with a risk as well. There's over reliance on patients and oral therapy safety because we are actually not providing them the tools. We're not providing them. We are talking to the patient. You need to take them. But in these days, the more drugs gets complicated, the most of the companies come out with a app. They will come out with some safety mechanism and say, look, this actually counts your drug. The packing is quite different. The packing, it obviously looks similar to the other drugs. The packing is actually made different so that patient can't confuse with the other drugs. Obviously, we don't have a safe prescribing systems where obviously you're still requiring paper and pen, and obviously the handwriting errors and the writing and giving the doses can be an issue. Electronic systems definitely mitigate that effect. They do not completely eliminate it because there's still human factor in prescribing, but it makes it a bit more safe. The staffing shortages, time pressures, systemic failures, these all lead to systemic failures, which can be very foreseeable and pre prevent the harm. In a study published by Ranchon in 2011, say the chemotherapy errors would cost 216 extra hospital days, and in Europe it costed extra 92,907 in cost annually. And you imagine this was about almost 14, 15 years ago, and the drugs are about 10 to 15 times even more expensive. These errors are in millions. Emotional harm to patients and clinicians, obviously. So it's a stressful situation when an error is made for the doctors, nursing, patient, and supportive care to the patients as well. Obviously, medical legal relevance really comes down to that we need to demonstrate the damages, we need to have the, and obviously the breach of the expected standards are how we calculate the economic cost. Things that have actually worked to mitigate those risks are really uh, obviously we need to have the pharmacy support where intensified pharmacists or clinical pharmacological support, they go through the patient history, they go through the bloods, they go through the indication, they go through the protocols uh, to make sure that we are actually prescribing the right thing. And they will come back and ask us the question, are you sure you want to do this? Why? And how you calculated the doses. My calculations shows this is not. So there's lots of background work, which means if you do have a good pharmacy service, it does work very well. They also bring into the fact, what is the patient currently taking? What is the guide? What is the timelines between the one treatment to the other treatment? Where obviously have you given them enough time to get rid of the side effect from the previous treatment? So there's a lots of factors which comes into the play as well. Most of our drugs are excreted by the kidneys or the liver. So obviously, if some of the cancer patient have already got pre-existing damage to the livers and the kidneys, you can't give them 100% of the doses. So you have to modify the doses, and you have to have a blood test before every chemotherapy so that you're giving them the right doses. So those things does need to be accounted for. Obviously, the more computerized order entry we have, it reduces the prescribing errors. We have more handover tools, more multidisciplinary coordination involved. It decreases the and decreases the errors as well. What can we do for the oral one? Obviously, we need to ask the patient to bring their medication before and after. So you actually need to see how many they have actually taken. Some people say, look, we're going to give you, and you give them only for the one cycle only, which could be 2 weekly, 3 weekly cycle. This is what it is. You need to show me the next time when you actually come back. That just you are aware that they actually taken it. Some bigger hospital with bigger resources have got oral chemotherapy nurses, pharmacists, which basically they will check and talk to the patient, and bit more drug education. You need to be asking, we teach our registrars as well, you need to be asking about over-the-counter meds. Patients say, I don't take anything, and then they start, oh, I take multivitamin, oh, I take some mushroom, I take this, I take that. Everything has to be explicitly asked and documented. Written patient instructions. Patient might actually say that, okay, they understand. Give them the instructions. Make sure they have something when they go home to hand, because people might forget. Uh, any chemotherapy patient will have some degree of short-term memory impairment. So they have to be given written instruction. It's always a good idea to involve their family members so that they also have a second set of ears to listen. I normally, when they do start with the oral medication, I tend to see them within the first cycle without finishing the whole cycle, within the first 2 weeks, just to make sure that they understand it, no immediate side effect, etc. 67.8% of errors detected at therapy start. Early intervention. So first month is important. You get it right, patient get into the pattern, and that's a lot easier to do. Just the last way is to, what are the medical legal implications for the errors? What is the standard of care? We are asked these questions in our medical legal report. What was the standard of care? Standard of care is oncologists, you getting a referral from a GP or a surgeon. You see the patient, you provide them the diagnosis, you provide them a treatment plan which is endorsed by, which is standard treatment. In Australia now we all use or the New South Wales guidelines called as EVQ guidelines. These are standardized protocols which are constantly updated, and they have patient information. We are all using the standard of care. We're providing them the same, we are same using the doses. We are not just, and there has to be documentation. Are we giving the 100% of the doses? If you're not giving 100%, why are we giving less than all the doses? Or if there is toxicity, there is actually specific guidelines to say, look, uh, we can give them, if there is a liver impairment, mild liver impairment, 25% of the doses has to go. Moderate impairment, 50% of the doses has to go. So that are what we call is a standard of care. This is what we define the way we treat it. Did we provide them the patient education? Did we sit down with the patient, answer the question? Did we give them an opportunity to ask the question? Did we actually do everything to avoid the errors? Was the documentation okay? If we do the errors, did we actually go into the open disclosure? Did we tell them we made a mistake? So that happens only in 35 to 45%. In 55% of the cases, we are not telling the patient we've done a mistake. It is the patient who goes around, finds at a later date whether it's a freedom of information, etc. Or did the organization have a system safeguards in place? Did they have handout? Did they make sure that there's a double checking, etc.? So those are the stuff needs to happen. Was it a public and the private? Private can be a little bit more difficult where the checks are much less, whereas the public system could have multi layer and hence is a lot of double handling, but also means double risk of errors too. So not necessarily putting too many people in the system makes it safer. Also, on the other hand, in private, too thin also predisposes to errors. So you have to have the right people in it. So that is all what I have to present today. But I think it's one of those things where the oncology itself in the last 10 to 15 years has got more complicated. We've gone towards the point where we just do on chemotherapy. We do a combination of chemotherapy, we do immunotherapy on its own, we do chemo and tablets. So immunotherapy and tablets, and all these have a different range of side effects. In terms of the side effects can be very subtle. It requires a lot of education. Some of these side effects are such as being tired, and those side effects could just means you actually having issues with a gland and it needs investigations. So those kind of stuff are very important, and I think until unless we don't reinforce the patient education, it can be quite a significant issue. So I will hand back to Taylor, but I'm happy to have any questions if anybody has any questions.
Thank you so much for that, Dr. Dua. It was such an interesting and very detailed seminar that you provided. Now it's time for audience questions. So if anyone has a question, you can either unmute yourself or type it in the chat, and Dr. Dua will be happy to answer them right now. We'll just give everyone a moment to either unmute or type in the chat. But while we give them a moment, I actually had a question sent in from somebody who couldn't be here today. Their question was in relation to the drug and food interactions, and you mentioned over-reliance on patients for oral safety. Their question was in relation to how prevalent is this as an effect, and how is this mitigated by the treating practitioners?
I think two ways. I think with our patient information sheets, obviously, if I say, look, I see a patient, I say, look, this is your diagnosis. I want to treat you with these drugs. When I give them the handout, which is a patient information sheet, which is usually 8 to 10 pages, one of the section does carry what foods to eat and what not to eat. So essentially, usually the interaction with the food is pretty predictable. There are some fruits, such as the grapefruit, some have got high potassium ones. Those are the stuff that we can actually predict to say, look, don't do this because this makes it more toxic. And during that process during the process of the drug development, we've already identified that these are the food which does not work because we've done the products and there's been a lab testing and stuff. So from that perspective, if the patient sticks on to what's not needed, it actually works. Okay, so food is usually least of a least of a problem. And also the issues around the amount of food they actually eat, and that's where the constant every visit you actually tell them and say, look, this is what needs to be, and every time they, and just try and actually reinforce those ideas and any questions as well. So it becomes second nature once we bring those conversations.
Perfect. Thank you for that detailed answer. We have another question from the lovely Paula Shelton in attendance today. Paula has asked, her question is about causation. So she's wanting to know, how would a lawyer prove that these errors have caused the patient an injury?
I think it starts off at the end because it says patient will come back and say, look, I have s- just same example, breast cancer, that I have these nerve endings which are actually affected. So that's where you need to go back. That's actually your starting point, and they say, look, this is what I've got. Or they might have said my whole arm is discolored, or you actually said, look, I've lost the strength in the muscle. So that's where your starting point. Then you actually go back and select what medication was actually given. And then the next step is obviously what part of the treatment was given, how long was it given, what doses were given, and was then if everything stacks well and so look, everything was given according to the protocol, because some things what we can't control is how side effects do happen. But the biggest challenge is really what did we do to stop it? Because if patient is getting a significant side effect that they can't walk, significant pains, that's toxic. That has to be stopped. Did we stop the treatment on time? Because we may stop the treatment just after one dose and patient may continue to have the side effect. That's okay. But obviously, if we, despite knowing that the patient had significant side effect, we made no efforts to actually mitigate the side effects, such as stopping the drug, decreasing the risk factors, providing them other medications to stop it. That is where the actually the errors actually comes down to. And then obviously we do have the FOIs where we would actually request notes and look at all the doses and getting the experts to look at it and look, this is what it is, what's the right doses, but not acting at the right time, in my view, causes the biggest challenges.
Thank you so much for that
Okay.
answer, Dr. Dua. If nobody else has any questions, I appreciate you so much, Dr. Dua, for taking the time out of your day to give this wonderful seminar. We'll have to wrap it up here now, but I also want to thank everybody else for attending. And I hope you all have a wonderful rest of your day, and we look forward to seeing you at our next seminar.
No, thanks so much. Thanks.
Thank you,
Bye.
everyone.